interest in uroradiology in general and prostate from a research point of view. So the talk today will be in and around prostate MRI and prostate cases, particularly geared towards the 2B examinations and what you would need for that, but also beyond that, because it is quite a subspecialist technique and indeed is beyond the level of the basic FRCR. We're going to start straight away with a case. So I think we do have candidate 1 available. So this is the history for your case, case 1. 82-year-old man, PSA 71.65, and has had a previous low anterior resection for rectal tumor. So I'm going to switch across to the viewing platform. And you have a CT, so you should be able to take control of the mouse.
Hi, sir. You hear me?
Yes.
Okay, I'm requesting control now.
Yes. Hopefully you have control.
So I'm presented with a CT scan in the arterial phase of an abdomen and pelvis. I'm scrolling down the images. You can see there are multiple enlarged pre- and para-aortic lymph nodes and retroperitoneal heterogeneously enhanced lymph nodes with some necrotic areas inside surrounding the aorta. There are multiple also common iliac lymph nodes as well. I scroll down. You can see there are some contrast in the urinary bladder, and there is heterogeneous mass involving the region of the involving the prostate, mainly at the posterior and left lateral aspects, encroaching upon the both neurovascular bundles bilaterally. The fat planes between the posterior aspect of the urethra and the anterior rectum is obliterated, and there is Foley's catheter seen within the urethra. So I'm scrolling back again, and there are abnormal also rectal mural thickening. So in the settings of the low anterior resection of this lesion, I would consider a prostatic carcinoma, recurrent prostatic carcinoma with rectal involvement and multiple upper abdominal lymphadenopathy, metastatic lymphadenopathy involving the pre-para-aortic common iliac lymph nodes with necrotic centers. So in my routine practice also, I would check for bone window to check for any deposits in the bone. And I will go for MR, dedicated MR rectal protocol or a prostatic protocol for further evaluation of the tumor. And of course,
what else can you tell me relating to the rectum? Just have a quick look up and down the rectum.
Okay, can I have a sagittal plane as well?
You can reformat, but it's probably not the most rare. It's just a very quick thing. So around that.
Okay. So in the rectum there is abnormal invasion, or there is a rectal tumor involving the anterior, and I believe this is a mid and low rectal tumor. Although I would confirm that on the sagittal image or MRI dedicated study for the rectal protocol to further evaluate the lesion if it's primarily involving the rectum or originating from the prostate and the involvement of the Dunvilliers fascia between the prostate and the rectum as well.
Okay, and we have a raised PSA. There's the history. I'm taking control again. There's the history of the rectal cancer, and there's these clips right from the low, and that was the surgical suture lines that I just wanted.
Yes. Yes.
I was aiming towards. So I think one of the first rules of radiology is that the larger a lesion is, the harder it is to work out its origin. If we trace this around, often if you point to the center of where a mass is, that's often quite circular, that can give you a clue as to where it originates from, because things tend to grow out like a ball. They don't always necessarily follow that pattern, but as a rule of thumb, that can give you an idea. So actually, if we look at this, the center is around here. It looks more centered on prostate than rectum. We do have a clue with the PSA being 71. You have another clue that the session's about prostate rather than rectum. That's a superficial clue that you won't get in the exams, unfortunately. But it could be one invading the other. And certainly if you had invasion of the prostate, that would be something that could push up your PSA. Perhaps not quite to that level, but that's circumstantial evidence. Either way, an MR would give us more detail about the primary and might help us plan to how we would get tissue, whether that's from a prostatic biopsy, rectal biopsy with sigmoidoscopy. So it can be helpful to decide that. It might not be straightforward to decide whether you want a rectal protocol or a prostate protocol, and perhaps you do an amalgamation between the two, or you add in the things in the prostate protocol that wouldn't be in a rectal protocol. Like, for instance, we typically do give contrast with prostate MRI and do that as a dynamic contrast enhanced sequence with multiple acquisitions. What I'd also say is I would be careful about stating things in the prostate on a CT. If it's very large, like in this case, then absolutely it's reasonable to do it. But more subtle things in the prostate, I see that overcalled all the time, that people suggest prostate cancer from a CT, which is a very difficult call to make. When it's obvious, but for the more subtle things, I'd be very careful about calling things in the prostate on CT. The other thing to be worried about on CT is the median lobe of the prostate protruding into bladder. And it's not uncommon for us to see that overcalled as bladder tumor. Again, the sagittal plane can help with that and trying to see that it's contiguous with prostate. But be careful when commenting on the prostate on CT. And I've deliberately started with a case that is CT, which we're more familiar with for most of you, and to move into the other topics. Okay, so that's the end of the imaging review for case one. So let's move on to some discussion about this, and then we'll start the rest of the slides. So I'm going to switch back now to PowerPoint here. So case one, we've reviewed. This is actually the MRI from case one. So obviously we can see a lot more detail on the MRI than we could from the prostate, from the CT. So we can see the catheter in there, and we can see, as we sort of implied, that the center of the mass was over here, and it does look centered on prostate. And it's quite a heterogeneous, unusual lesion. There is involvement of the rectal wall. It's quite cystic in places. This turned out to be favored to be a prostate primary. Tissue was acquired actually from sigmoidoscopy, and quite a complex tumor. And I think you mentioned that you thought that they might be necrotic nodes or they might be septic nodes. Certainly there was some low attenuation in several of the lymph nodes in the upper abdomen and the pelvis. And that's probably not surprising given this cystic appearance of the primary, because often the nodes look like what the primary looks like. So if you think of squamous cell carcinomas with having quite necrotic nodes and osteosarcomas that can be calcified, the nodes are often calcified. So it's not uncommon for the nodes to look a little bit like the primary. So I think these are sort of cystic stroke necrotic nodes rather than septic. But we can see a lot more detail with MRI, okay? So this is the prostate on CT, most typically, a relatively homogeneous appearing, whether it's post-contrast or unenhanced, and you can't easily differentiate any of the anatomy within the prostate, or as I was saying a tumor within the prostate. So we can't even tell a distinction between peripheral zone or transition zone, and it's very difficult to see the urethra unless a bladder is in place. This is a CT, same patient, not the one we looked at, but the same patient with this imaging. The T1 imaging also tends to be quite homogeneous, intermediate to low signal on T1, and you don't get any of that zonal anatomy, and you can't see tumors. You can see hemorrhage if there's been a previous biopsy or spontaneous hemorrhage into nodules within the prostate or tumors. And then this is the T2 in the same patient. So we can see a difference between the transition zone and the peripheral zone, but we can also see this large tumor, huge tumor, occupying almost all the prostate, and there's no way of telling that on either the T1 imaging or indeed the CT. And CT will tend to overestimate prostate volume. So this can be important for radiation oncologists when they're trying to plan their radiation fields and they're trying to minimize any radiation to other organs at risk. So we can see in this example here on the CT, and this is a post-contrast CT, there's no way of saying that what we've outlined here is not all prostate. But actually, which is not uncommon, there are some periprostatic veins on either side of the prostate in this case, and also a prominent venous plexus anterior to the prostate. And you can see the veins on the DCE sequence here where I've put the arrows. And actually, the yellow line, which we thought might be prostate from the CT, is a big overestimation, and it's the white dotted line here that actually represents prostate. So we get incredibly good anatomical information and anatomy on MR, and then that's when we can start to see tumors. This is something that you might need to know for the purposes of the exam, is how prostate MRI is, what is the workup of prostate cancer, and where does prostate MRI come in. So since 2019 in the UK and since 2020 in Europe and America, the initial diagnostic test for suspected prostate cancer is MRI before any biopsy. So prior to that, it was a systematic, relative randomized biopsy, sticking needles into the entire organ to try and establish the diagnosis. But now we do MRI before we stick needles into the patient, assuming they're otherwise fit and well and suitable for active treatments. The first step will be MRI, and in low probability cases, avoid any subsequent biopsy, and in the higher probability cases, directing the needle to the abnormal areas on the MRI. So that's quite a big change in practice that's happened in recent times, and questions can arise around that concept, either in the written exams for the FRCR or in the practical 2B vivas. I think a disclaimer for this, and as Sammy said, this is not just for the FRCR, it's a bit beyond that, but it's not enough for you to be able to independently report prostate MRI just attending this session. It's a mix of lots of things, and there's been a lot of debate about this in the community and a move towards certification to be able to read prostate MRI, even once you've got the FRCR and you're practicing as a consultant. And that's a mix of things. That's the experience of reading with somebody else who's experienced to start with, doing approximately 200 cases with second reporting, attending the MDTs where there's input from urology, oncology, histopathology, seeing what the outcomes of biopsies were and prostatectomy to get that pathological feedback, attending workshops, attending sessions at conferences, attending sessions like this, that you can accrue CPD points. And it's a portfolio of all those things together that makes you independent in prostate MRI reporting. So it's beyond 2B to be independent in prostate MRI reporting. And this is, I'm on Twitter. You can follow me on Twitter. I put my handle up at the end as well. This is quite a nice analogy from one of my colleagues in urology in North America. And it can be difficult to see that owl. It's very well disguised. It's evolved well with its environment. But you can see it once you know where to look. And the best way to learn is to learn from somebody experienced who tells you this is where the abnormality is. And then you start to learn those features. Looking straight off, it's much harder to spot the owl. When somebody tells you, look here, then you can see where the owl is. So what does prostate MRI involve? So you may hear this term, multiparametric MRI. We use it in other contexts as well. Essentially, it's a slightly fancy term for meaning we're incorporating our standard anatomical images. And as I've shown you, T2 is key for that rather than T1. And we're mixing that in with some functional sequences. The two functional sequences we use are diffusion weighted imaging and DCE dynamic contrast enhanced MRI. So as I've already showed you, we can get really nice anatomy around the gland. We can see the difference between the peripheral zone on the outside, the transition zone in the center, and all these nodules of BPH that we get in the center. We also see these two triangular areas here. Now, there's no real way of knowing that these are cancer or not. And if I told you one is and one isn't, you really wouldn't have a way of guessing. You would be flipping a coin. You wouldn't be able to tell me which is more likely than the other to be cancer. If I tell you one is benign, one is cancer. But if we use our functional sequences, so the diffusion weighted imaging here, and this DCE video will play, you can see some early enhancement there on the DCE. So our B-value imaging and our ADC maps, we can see bright here and correspondingly dark to confirm restricted diffusion on the ADC. And that's the area that has early enhancement on DCE. So that's the more posterior of these triangular areas, whereas the anterior one has little or no change on the diffusion and no enhancement on the DCE. So despite the nice anatomical information we got there, we can't tell the functional difference between those. And the more posterior, we can clearly see marked restricted diffusion, early enhancement at DCE. So that is positive, and that was the tumor. Let's cover a little bit of anatomy first before we get into some of the cases. So I think this case is nice in that we have a catheter going through, because you can't always see easily where the urethra lies within the prostate, because you have BPH compressing the urethra, and unless the patient is passing urine at the time of the examination, which they're not likely to be, the urethra is not distended. But with a catheter in, we can see nicely where the urethra runs. So catheter in the bladder, prostate here, sagittal image, obviously. This is what I was talking about earlier, about the median lobe of the prostate protruding into bladder. So that's not uncommon for us to see. And as I say, be careful not to confuse that with bladder cancer. It can be difficult on CT. The sagittal images on CT can help. The urethra we don't always see nicely, because if we think about axial imaging, it's cutting across the plane. So we're seeing it obliquely coming through the plane in our axial images, and we don't always see that with partial voluming. And by the time we get down to the apex, the lower part of the prostate here, we do see the urethra coming at us directly, so we have more chance of seeing it. We typically do see it at that lower part of the prostate. So how do we divide the prostate? So we go from the back of the prostate, if we think of a line like that, and then we divide it into thirds. And we talk about the base, the mid, the apex. Why those terms? Well, it's sort of like a triangle, or a three-dimensional triangle, a pyramid that's inverted. So it's on its tip. So the apex of that pyramid is at the bottom, the base is at the top, and the middle bit is the bit in the middle. Now we divide that into thirds, but based on the back of the prostate, the peripheral zone. So actually, this stuff here that pokes into the bladder doesn't count for the purposes of dividing into thirds. It's the thirds based on the back of the prostate, equal thirds, when we talk about base, mid, and apex. And this is equivalent axial images at each of those levels, base, mid, and apex. And then this is a coronal image. This is taken from the PIRAD sector map, where we describe the classical division of prostate anatomically. So that's the PZ, the peripheral zone around the outside, the central zone, which is different tissue at the base level of the gland, the transition zone, which surrounds the urethra, where BPH occurs, the anterior fibromuscular stroma, and then the urethra coursing through. So that's the typical McNeil anatomy that's described in the 1970s that we use to describe the prostate. So let's go through them one by one. So let's start at the base level, the green stuff up here. This is the central zone, which is located at the base, compressed between the peripheral zone and the transition zone. And it surrounds, you can see here, the ejaculatory ducts. So this tissue follows the ejaculatory ducts as they come off the seminal vesicles and follows them down until they join with the urethra at the level of the verumentanum. So you can see the dots of high signal intensity within the ejaculatory ducts at that level. And you can see how it goes from out to in on the coronal imaging. So it's following the course of those ejaculatory ducts. So embryologically, that is different tissue, and that's why it has this low signal appearance on T2. It can be confusing with tumor. The key is to, number one, know it exists, and number two, see the symmetry and be able to follow it down around the ejaculatory ducts. There are some other tricks with the functional imaging. I mean, typically it doesn't have marked restricted diffusion, which is the way of differentiating it. But the key thing is its location and its symmetry. Next, we have the anterior fibromuscular stroma, so blue in the diagram, and I've colored it blue here. So as its name implies, it's anteriorly located, and as its name also implies, it's fibromuscular. So it has quite a low appearance in the T2 weighted imaging. Similar, getting towards the low signal intensity of the muscle. So you can see here the obturator internus muscle at the side. It has that sort of signal intensity. So the anterior fibromuscular stroma. Now, tumor doesn't occur in that because it doesn't have any glandular tissue, but it can occur in tissue adjacent to that and invade into the anterior fibromuscular stroma. Next is the transition zone. So not transitional zone, but transition zone. And actually, that's quite a nice thing to be able to get correct. People in the know will spot that if you say transition zone rather than transitional zone. I've colored that in yellow here to match PIRADS. So that is located around the urethra. You can see some high signal within the urethra there. This is the urethra here as well. And that's tissue where BPH occurs. That typically gets bigger as men age, but you can get tumor within the transition zone as well, and it's harder to interpret. So that's the transition zone in the center of the gland. And then finally, we have the peripheral zone around the outside in pink here, usually high T2 signal intensity, and that's where the majority of tumors occur. Now, people sometimes use the term central gland, which incorporates the central zone and the transition zone. I would caution against that. I think it's better to stick with this terminology used by McNeil and to use those terms zones. So the central zone is a very different tissue. Tumors there are very rare. So talk about the central zone, meaning specifically that portion, the peripheral zone around the outside, the transition zone in the center where BPH occurs. Okay, so that's an overview of the anatomy. Another important thing about the anatomy is where does the prostate start and stop? So this is from a reader study never published that I did several years ago when I was a fellow in Toronto. And what you can see is this is a mix of 10 different readers with different levels of experience. When we're in the middle of the prostate, the mid-gland, we're all pretty good, right? We all know exactly where the prostate starts and stops on MRI. When we get to the base, it gets a bit trickier, and some people here have included the seminal vesicles at the back. And when we get to the apex, it's even harder, right? Some have included all this periprostatic fat around here, and some have got different margins around. So it's harder when we get to that point. And that can be important for radiation therapy planning, that can be important for biopsy planning, and it can be important for us to if we're asked by those different parallel specialties, but also to know where prostate finishes, to know that we've evaluated it all, to make sure that we haven't missed any tumors. So you can see on the coronal imaging here, you have what's termed the urogenital diaphragm, the external sphincter, which is an amalgamation of muscles coming together. And what it creates at times is this hourglass appearance that you can see on the coronal imaging. Absolutely, the secondary planes will really help you to identify where the lower apex is. And if you're looking on the anatomical, on the axial imaging here, you can often see this hourglass-like appearance. That marks the last slice of the prostate. So we know on the next slice down, we're off prostate, and we know certainly on the slice above that we're still on prostate. So you don't always get that, but you can see why you would get that with the urogenital diaphragm. But the coronal plane and the sagittal plane can help you identify where the lower portion of the apex is. But this can be a useful tip when it comes to the axial imaging. And why is it important? Well, as I've alluded to in this case here, we're still at the hourglass level. So we're still on prostate here. And there's this focal area of low T2 signal, but more importantly, marked restricted diffusion, high signal on the B-value imaging, low signal on the ADC. And if we didn't realize we were still on prostate, we might have missed that very low tumor within the prostate. Okay, so that's an overview of the anatomy. This will scroll through. So we've got axial imaging here, and we've got coronal imaging here. That's again showing us what we've seen before on those still images. So bladder has high signal intensity fluid, seminal vesicles, high signal intensity fluid. The ejaculatory ducts were coming down there. The peripheral zone around the outside, where the majority of tumors occur, the normal peripheral zone looks high signal intensity on T2, and tumors are focal low T2 signal intensity. The transition zone is a very, very mixed signal intensity, areas that are very high, very low, everything in between. Described as organized chaos, which is a nice term to think about this and to appreciate what the normal transition zone looks like. And again, tumors are low signal intensity in the transition zone, but because the background is much more mixed, it's a harder thing for us to detect. And the seminal vesicles I mentioned will have high T2 signal intensity fluid within them. And if they're invaded for staging purposes, again, it will appear as focal low T2 signal intensity. Okay, so we're going to go to case 2. So if candidate 2 is ready, I'm going to close the PowerPoint here, and then I'm going to start to share. Just have to get off laser pointer to close PowerPoint. And let's go back to this. So I'm just going to get you on to the case here. So the case was a 62-year-old man with a PSA of 4.85, and you've got the prostate MRI. You should have, if you request control, then I can give you control of the mouse.
Yeah, requested.
Yes, and let me give you that. So talk me through. Do you have much experience in prostate MRI?
No.
No. Okay. How do you think you would approach looking at the prostate MRI?
Okay, so I'll check the I'll start with the T1 and T2 and check the sagittal and axial coronal and see if I can spot any abnormal signal intensity in the prostate given the mild elevation of the PSA in this patient. And if I see any abnormal signal intensity in T2, I will check the diffusion and ADC to check to see if there is restricted diffusion. And if I have, definitely will have like dynamic contrast series, I will look at it as well. And if there is something more than like just a small lesion, I will definitely see if there is invasion. And for any patient, I will check for lymph nodes, regional and distant as well. Yeah, this is, I think, based on what I have listened from you.
Okay. Well, no, that's very good. So let me just so why don't you try to just scroll through on the T2?
Okay. In this case, or just like I verbalize?
Just for this case, yeah. Just have a quick look through.
Okay. Yeah, the base of the bladder where the prostate is around the urethra. I check the zonal anatomy. So we said that the peripheral zone is the higher signal intensity, which is this one. And okay, so I can see that there is yeah, it is of high signal intensity, and again the central the transition zone is of heterogeneous signal intensity. Yeah.
Okay.
Not sure if I can see any lesion.
That's fine. That's fine. I'm just going to take control. We both have control, but I'm just going to manipulate this a little bit. So let's put these different things on. So you would have the diffusion, and let's just very quickly put up the DCE sequence. So yeah, I think for the purpose of the exam, the terminology is always very good to get right, as we mentioned, and a systematic approach to how you will review the imaging is also of benefit. So I will talk through how I do a case, but I would start with the T1 imaging first to make sure that there's no hemorrhage in the gland, and also I can use that to look as an overview of the bony pelvis. The T1 we typically do as a large field of view from the bifurcation downwards, so it includes all the pelvis. Have a look at the bony pelvis, can have a look at the nodes, nodal stations, can see any other incidental findings. Then I would move on to the T2, and as you described, trying to look at the T2 in isolation. Then after that, use the diffusion weighted imaging, and as you sort of implied, not everyone does do DCE, and then you would look at that third. So it's a stepwise approach of looking at the T1, yes, initially the T2 diagnostically, then adding in the DWI alongside it, then adding in the DCE after that. So there isn't a lesion in this case. What there is here is there's this big black hole here, right? And this here.
Yeah.
And there's those areas there, and to a lesser extent on the DCE. So what do you think about that?
So it is of low signal intensity in T1, and again low signal intensity. It's calcification, I think.
But how would you describe it? Not rather than what's causing it. What do you think?
Yeah, it is two foci of signal void in T1, T2 with no restricted diffusion. So it is again signal void in all sequences in T1, T2, and diffusion ADC. So it might be an area of calcification.
Okay, so it looks artifactual, right? It doesn't look like this is a genuine pathology or normal anatomy. So the area is much more marked on the diffusion than it is on the T2, and on the DC it's somewhere in between the two. Yeah. And it looks like it's projecting into bladder. So it looks sort of like either susceptibility artifact or blooming artifact. So calcification might be a thought. It looks a bit more marked than we get with calcification. Any other kind of quick thoughts of what might be causing this?
Is it processes like if the patient has it's in the prostate, so
okay, you've got somebody in the chat that's tried to help you out. They've put radiotherapy seeds. So that might be a thought. Yeah. So some sort of metal that's iatrogenic that was put in for treatment purposes. Okay, that's good. I'll take back control, and we'll go back to the to the PowerPoint. So my point with this case is really just having a systematic approach to how you would look at the MRI. And actually, one of the difficulties that we have with prostate MRI is that we do have quite a lot of artifacts. So I'll go through what some of those more common ones are, and then we'll talk about what this slightly unusual one is. So these are the more common artifacts that we get with different sequences, and they can affect any of the sequences. Motion tends to a bit more than the other sequences. And susceptibility artifact relating to metal work particularly can affect the diffusion weighted imaging and wrap up. I seem to have lost you briefly there on Zoom. Can you hear me again, Sammy?
Yeah, we can.
Okay, great. Sorry, I seem to have dropped out there on my Zoom connection. I'll go back to PowerPoint. So Yeah, so the artifacts, so they will occur potentially on all of them, but these are the ones that particularly affect those different sequences. And motion, patient motion, that they're moving around on the scanner. Respiratory motion is an issue because we're deep in the pelvis, so unless the patients are particularly claustrophobic.
Excuse me, there is a drop down on the PowerPoint which is on your text actually. You on the left side, which is hiding the text actually for us. Are you with us, Tristan? You are frozen, I believe. I think Dr. Barrett Zoom is frozen. Let's see. Yeah. So now you are unmute.
Yeah, let's go back. Sorry, some technical issues with the Zoom. Hopefully we're...
Excuse me, if you can show the artifacts once again. The slide was, showing us perfectly.
Is that showing?
But right now, it's not in. Hello. Yeah, now it's perfect. Perfect.
Okay. So yeah, the artifacts. So the most common artifact is motion artifact from rectal spasm. With the prostate being low in the pelvis, it's unusual to get respiratory motion artifact unless the patient's claustrophobic and they're particularly hyperventilating, and then you tend to get abdominal breathing as well. And occasionally then patients will move in the magnet if they're claustrophobic, or if they have other conditions such as an intention tremor, Parkinson's disease. But the most common is for us to see rectal spasm. And then air in the rectum can be particularly problematic on the diffusion weighted imaging and causing susceptibility artifact, as we see in the case here. In this case here, with some warping at the back of the prostate. And in this case here, there's a hip replacement with metal artifact and susceptibility artifact. So artifact and image quality are quite big things when it comes to prostate MRI, and getting those mitigating against them is a big issue in terms of getting good quality imaging and getting good outcomes. This is beyond what you need to know for the FRCR exam. There's a reference here from a review article I've done that describes the more common artifacts and image quality issues and how we can try to optimize image quality. Now, for the next one, I've talked about how I briefly would present a prostate MR. So I'm just going to show you about 3.5-minute video now, me going through a case and describing how I would approach that case and how I describe the abnormality. So we'll just quickly play that video for about 3 minutes or so.
So we have in the top left the DCE, dynamic contrast enhanced MRI. Next panel is the wash-in, wash-out curves that are generated from the DCE. So as you click on the pixel, you see the different curves that are produced. Top right is the T2 weighted axial imaging. Bottom left, we have the T1 weighted imaging. And then the next two panels are diffusion weighted imaging. The B-value imaging is the high B-value that we're interested in. You can see here, B2000. You can scroll through this to the lower B-values, but it's only the high one that we use. Ideally, more than 1400 to assess the gland. And then in the next panel, the ABC map, which confirms whether it's restricted diffusion. How I approach this, I would go through the T1 weighted imaging first in isolation to assess for any hemorrhage in the gland. And also this sequence continues up to bifurcations. We're looking for any nodes within the pelvis that are enlarged and any focal lesions within the bone pelvis. I try to start with the T2 weighted imaging in isolation to keep your T2 skills high, particularly if you lose the T2 weighted imaging artifact or you don't prior DCE, it's useful to be able to assess the T2 weighted imaging. We pay particular attention to transition zone, which is the dominant sequence on T2. But also looking at the peripheral zone, there's some low signal on the right-hand side, more so than the left. We'll pay attention to the peripheral zone and the diffusion-weighted imaging, which is the dominant sequence there. So if we now switch to looking at the diffusion-weighted imaging in conjunction with the T2 weighted imaging, on the B-value imaging, we're looking for any bright, high signal intensity. And you can see there is a focal area here within the right-hand side of the gland. The remaining prostate gland is relatively suppressed. There's no focal areas of high signal. And we can confirm this area is being black on the ABC maps. That is restricted diffusion. There is some distortion artifact in the air within the rectum here. You see the air on the T2 weighted imaging. So it's causing a bit of warping artifact and artifact in the midline posterior peripheral zone there. So that's what we're looking for to confirm restricted diffusion. High signal on the B-value imaging, low signal on the ABC. Those less experienced, if you have a quick blank and forget what that is, you can always go up the bladder, which obviously has very free movement of water, no restriction at all. And you can see the normal appearance of no restriction is no signal on B-value imaging and white, bright signal on the ABC in tumors, obviously with restriction on the opposite of that. Bright on the B-value imaging and low on the ABC map. We already have an area that we're interested in from the T2 and the DWI, and because the DWI is the dominant sequence and this measures more than 15 millimeters, we're already calling this PIRADS 5 lesion. We can switch to DCE, which is helpful as a safety net. You either use this when you haven't seen the lesion to pick up anything incidentally that you may have missed, or to confirm enhancement within the lesion to detect it. So if we go to the level of the lesion here, you can scroll through the DCE 4D data set. This is over the course of 6 minutes this is acquired. You can see the degree of spasm within the rectum there, but it's the early enhancement that we're interested in. So we go to the very first few sequences here. You can see there is an area of early enhancement there, matching that area that we've seen. There's no early enhancement in the remainder of the gland. You can drop a pixel on that, and you can see that this confirms early enhancement on the wash-in, wash-out curve. We're not interested in the washout, but it does wash out with a type 3 curve. So for this case, high probability PIRADS 5 lesion in the right mid-apex peripheral zone.
Okay, so that's how I would quickly approach diagnostically a prostate MRI, and that's a good system to have. So let's go on to a bit more how we interpret the images. So let's talk about PIRADS scoring. So PIRADS is the system since nationally recognized that tells us how to perform the MRI, the parameters to use, how to set up our sequences to get the best quality imaging, and then how to interpret those images to give a probability score 1 to 5, whether we think that there's significant tumor within the gland. So the first thing to note is that the T2 and the diffusion weighted sequences are scored from 1 to 5. And not surprisingly, the T2 scoring is different for the peripheral zone and the transition zone, because we've already at several stages now seen how different they look to each other. DCE, however, is scored out of 2. 0 or 1, yes or no, positive or negative, however you want to term it. It's not a 5-point scale. What we do, and we'll touch upon this as we go through some different examples, is we apply the dominant sequence paradigm to derive our final PIRADS score. And for good reasoning, in the peripheral zone, the dominant sequence is diffusion weighted imaging, and in the transition zone, the center part of the gland, the T2 is the dominant sequence. This slide looks very busy, and you don't need to know this. You don't need to know this really for the FRCR examinations, but this is the descriptors that are used for that score of 1 to 5. So as I've alluded to, peripheral zone, transition zone, there are different criteria that we're looking for. However, diffusion, regardless of whether you're in the peripheral zone or transition zone, it's the same principle that we're looking for. We'll touch back upon this as we go through. One thing to note is that even though it's a 5-point scale, it's almost really a 4-point scale, because the only difference between score 4 and 5 is this size cutoff or having invasive features. So you have to hit a threshold of 15 millimeters in size to be a score 5 rather than a score 4. Otherwise, the features are the same between the two. So it makes it a little bit easier. It's almost a 4-point scale or a 4+1 point scale. So that's the first thing. And the other thing is that scores 1 and 2 are considered negative. So score 1 is completely normal looking. Score 2 are normal, well, not quite absolutely normal, but features that go more with benign conditions rather than tumor. The difficulty is that score 3. The score 4 and 5 is strongly positive, and score 3, we're sort of sitting on the fence, and we don't like to have to do that. We want to be definitively one way or the other, that it's positive or negative. So let's go through some of the scoring. So for T2, and we're talking about the peripheral zone now, the score 2, so not completely normal, but benign features, are linear, line-like, or wedge-shaped areas of lower signal intensity. So you can see on the top row here, these lines that we've got within the peripheral zone. And that's quite common when we have blocked ducts with inflammatory change, previous inflammatory episodes, or it can just be a glandular appearance to particularly younger patients, the normal peripheral zone. And they can be more wedge-shaped in nature that we see on the bottom row here, these wedge-shaped areas, or indeed a combination of the two. So we've got linear areas here and then a wedge-shaped area there. So those are quite non-specific, but can often go with inflammatory change. Let's move into the transition zone. So one thing to note is that the prostate tends to get bigger with age. That can be to variable degrees in different patients. And as a general rule of thumb, younger men, the prostate is about 20 centimeters in size, the size of a walnut. At 60 years, about 40 centimeters, the size of a golf ball, and 80 years, around 60 centimeters, the size of a small orange. Then if we look at the score 1 in the transition zone, what we're looking for is this organized chaos appearance. So whilst this looks all quite randomly, lots of different signal intensities, actually when you look at it, it's all in a pattern. And it seems to be going together in groups, and these nodules where they have these pseudo capsules around them. So actually, despite being very mixed signal intensity, you can see in these cases here, actually very organized. And what we want to see are these nice encapsulated nodules with the pseudo capsules going all the way around. The score 2 is when it's almost like that, but not quite, and actually quite nicely visually depicted in the PIRADS guidelines here. So when you've got a pseudo capsule that's most of the way around the nodule, i.e. more than 50%, but not 100%, that's this appearance as a type 2. And then when you have a well-defined nodule that's homogeneously low signal intensity, that's also a type 2 nodule. So we can see on these ones here, if I go off and on, you can see those on the left are very 100% capsules all the way around, whereas this one on the right, it's not all the way around, but it's more than 50%. And in this case here, this is this one, which is homogeneously low T2 signal intensity, but well-defined around the outside. One difficulty is nodules of BPH that appear in the wrong place. And obviously that can be challenging because we apply a different scoring system, as we've touched upon for the peripheral zone and the transition zone. So most typically, these are quite obvious. They're just nodules of BPH that are poking out into the wrong place, and we describe them as protruding ectopic nodules. But occasionally, they can be rest cells that are completely within the peripheral zone and surrounded by normal peripheral zone tissue. And we refer to those as extruded nodules of BPH. Now, these are quite easy because they just look like nodules of BPH. They look like nodules of BPH that have gone on holiday or have ended up in the wrong place. So in this case, more cystic in appearance with a well-defined pseudocapsule. In this case, nice defined pseudocapsule and that mixed signal intensity that we see in nodules of BPH. This one is difficult. I don't think there's any way of prospectively calling this. It doesn't clearly look like a nodule of BPH. And the only way we knew that that was a nodule of BPH is they had a tumor elsewhere, they had a prostatectomy, and that was confirmed at pathology. So you will get those in real life, and there's no way of prospectively identifying them. But ectopic nodules of BPH in the wrong place, and it can be diagnostically difficult at times. So let's move on to what tumor looks like on the T2 weighted imaging. So as we said, peripheral zone, transition zone, we're looking for slightly different things, but ultimately we're looking for a focal area of low T2 signal intensity. It's just much harder in the transition zone because the background is different. So if we look here, I've highlighted those two areas there. You can very appreciate that that's more homogeneously low T2 signal intensity when I take the outlines off. But importantly, in these two cases, less than 15 millimeters. So not at that threshold to be a score 5. Score 5, the same sort of thing, but it's above a size threshold. So again, if we outline these here, quite easy in this case here to see that that's all homogeneously low T2 signal intensity where I'm highlighting in the transition zone, whereas the background is more mixed signal intensity. But actually, when you first look at this is harder to detect. So that's where you need to get your eye in for these, where it's a homogeneously low T2 signal intensity. On the peripheral zone, it's easier because the background is more high signal intensity. You've got the other side to compare to. And in this case here as well, there's starting to be extracapsular extension. So you can see where I've highlighted around, it's not smooth like the other side. So this is starting to go outside the gland, extracapsular extension. So that fits. Extracapsular extension is invasive behavior. And in this case here, there's involvement of the seminal vesicles, which is T3B disease. So those are other features to score as a score 5 with invasive behavior. And another feature of invasive behavior is involving both the transition zone and the peripheral zone. So I highlight where the peripheral zone lies. It might be difficult to work out the origin of this tumor as being peripheral zone or transition zone, but certainly involves the two zones. So it's invaded from one to the other. So that's showing invasive behavior. So that score 5, differentiating from 4, is the size threshold of 15 millimeters above, or this invasive behavior. Let's talk about diffusion now. So we think about free diffusion, Brownian motion, and then we think about restricted diffusion. So let's break this down into simplistic terms. This is more simplistic than it is, but it's a nice way of thinking about it and remembering it. So what you can think about is that as you go up in the B values, there's more time. There is actually more time. It's to do with the gradients and it takes longer to acquire. But you can think about this as time for the water molecules to move around and to lose their signal. So at the low B values, they have less time to do that. So actually what happens is, we'll scroll a video in the background and we'll come back to that, but you can see they haven't had much time to move here. So it goes to a slightly off-white color, but not much different. Then as you get to the higher B values, they've had longer time to move around and they go to a grayish color. And then as you get to the much higher B values, they've had more time to move around, they can lose all their signal, they go black. When it comes to tumor, it can start off the same, but then they're not able to move because they've got typically cells in the way that are impeding their movement. So it's acting to restrict that motion and they're not able to move around and lose their signal. So at the low B values, you don't see a difference between tumor and benign tissue. At the intermediate to higher ones, you can start to see a difference. And when you get to the higher B values, you can clearly see a difference. Now, you will be confined by the limitations of the magnet as to how high you can go in the B values, and you start to get noise in the system. So at a 3 Tesla magnet, you can easily go to 1500 or 2000 in the B value imaging. At 1.5 T, it's a struggle to get a lot beyond B1000. Ideally, you want to get to 1400, 1500. Now, with all of that in mind, if we look now at this video, you can see as it scrolls from the low to the high B values, this is a tumor over here, and you can't see it at all at the lower B values. And as you start to get to the higher B values, that's remaining as high signal intensity. So we're at this point here, and we can see tumor over background on the B value imaging. You can also see this nodular BPH up here. The problem with the transition zone and nodules of BPH is they can be quite cellularly dense, so they can also show restricted diffusion, which is one of the reasons, as we mentioned, the dominant sequence in the transition zone is the T2 anatomical imaging rather than the diffusion weighted imaging. So this video, as it goes through, shows these principles we're showing there, and we want to get to that higher B value as we can possibly get within the confines of the of what our magnet will allow us to do. So we've briefly looked at this. We'll touch upon this again. Diffusion weighted imaging, same in the peripheral zone and transition zone, and it's sort of what you know, right? We're getting to the point where a score 4-5 is where we have marked change of high signal on the B value imaging and marked change of low signal on the ADC map. And the difference between 4 and 5 is the size threshold or invasive behavior. So that's what we're trying to get to, or that's what we're thinking about looking for. When we're at a score 1, actually, if we've got to a high enough b-value, all the normal tissue suppresses out. And the ADC map, because it has basis in T2 weighted imaging, essentially kind of looks like a T2 weighted image with high signal intensity within the peripheral zone and this mixed signal intensity within the transition zone. But importantly, you would have suppression of all the signal on the b-value imaging. Then the score 2 is when you have this mild change on the b-value imaging, mild change, the mild high on the b-value imaging, mild low on the ADC, and often wedge-shaped or linear in appearance. And then the score 3 is when you have marked change on one, but not the other. So in this case here, it's marked change on the ADC map, but it's not marked change on the b-value imaging. So it doesn't fulfill the criteria. So it's marked on one, but not the other. And the score 1 is when you don't have any change, and score 2 is when you have mild change, but it's linear or wedge-shaped in appearance. Okay, so that's the diffusion. The other thing that I'll briefly say on this, I think it's very useful to standardize your windows, because you can make an image look as bright as you want, or you can window it to make it look as dark as you want. So you do want to standardize them so you can make that call, as we've showed on this one. What are we sure that this is marked change on the ADC map, or is it more mild change? So this generally works quite well. It's a window width and level of 1400. So as a reminder of what that means, we use this a lot in CT. That means that we're setting our grayscale within those confines. So the window level is set at 1400, ADC values of 1400. The width is 1400 around that. So 700 this way, 700 this way. We're setting our grayscale there. So less than 700 will appear black. More than 2100 will appear as white. And we have the grayscale where we want it to be to maximize our ability to diagnose tumors. And once we get to these, the lower ADC values that are consistent with tumors, that's when it will start to appear as a more black appearance and what we would term marked restriction. So standardizing the windows, that will change magnet to magnet, and you might have to work out on your own magnet if you're doing this later in your career diagnostically, but standardizing the windows is key so you can make that subjective call of marked change as objective as possible, okay? So DCE, prostate tumors, like many other tumors, will do this. Once they get beyond a certain size, they have to grow their own blood vessels in order to get nutrients from the normal blood system. Now, they don't do this in a particularly organized manner. So they form new vessels, neoangiogenesis. They form new blood vessels that are very leaky. They have permeable membranes. So what happens is when we inject our standard contrast agents that we use in CT or MRI, the low molecular weight agents, they don't leak out of the normal vessels, but they will leak out of these tumor haphazardly organized vessels. So we will see that as enhancement within the interstitium. So we'll see early rapid enhancement, and also they can then go back into the blood system and wash away. So we will see that then as washout. So that's not a unique feature for prostate tumors. Many tumors do that, and some are more hypervascular than others. If you think of neuroendocrine tumors or HCCs or clear cell carcinoma in the kidney, they tend to be very hypervascular, but tumors do this to a different degree, and prostate tumors are no different. So we've mentioned already that we're looking for a 2-point scale, positive or negative. And actually what you need to be positive on DCE, and you can see how downplayed DCE has been versus the other two sequences, you have to have 3 criteria to be positive. It has to be focal, it has to enhance earlier than its background normal zone, peripheral zone or transition zone, and it has to match a suspicious area on either T2 or DWI. So if we look at this focal low signal area on the T2, you can see there's an early enhancement there on the DCE as that video plays around. It's focal, it's earlier than the background, in this case, peripheral zone, and it's matching that abnormality on T2. The reason DCE is not so good in the prostate versus, for instance, breast MRI is that in the peripheral zone, we can have inflammatory conditions, prostatitis that can enhance, and in the transition zone, BPH nodules are very typically quite vascular, so they will enhance as well. So we're only looking for this early enhancement. We're not actually interested in the washout, and it has to fulfill those 3 criteria: focal, earlier than background normal tissue in that zone, and matching an abnormality on T2 or DWI. So I've touched upon this a couple of times, the dominant sequence principle. So there's a good reason for this. So when we're in the peripheral zone, areas of low T2 signal intensity are not only caused by tumor. So these are examples of all of these different conditions that can cause low signal intensity change on T2 in the peripheral zone. So it's quite non-specific. So in this case, prostatitis, we've shown some cases of that with linear change and wedge-shaped change. In this case, I haven't shown you the T1, but there's diffuse high T1 signal within the peripheral zone due to previous biopsy, and this is causing diffuse low T2 signal change. In this case here, it's a very, very low change. It's too low. It's as low as the muscle or the fibrous tissue. So this is scar tissue from previous inflammatory episodes. In this case here, very diffuse change within the peripheral zone and almost looking a little bit like the transition zone. So loss of that zonal anatomy. And this is a young patient with a very glandular, age-appropriate peripheral zone. So this is a patient that was around 46, 47 years of age. Increasingly, we're seeing this as we're scanning younger patients, and patients particularly under the age of 55. It's typical to see that glandular, age-appropriate change in the peripheral zone. And then this is a patient that had hormone therapy, so this sort of diffuse change, shrinkage of the gland, and again, loss of the zonal differentiation between the peripheral zone and the transition zone. Now, the good news is those conditions don't have marked restricted diffusion typically. So they might have mild restricted diffusion, but they don't have marked restricted diffusion. So that's where DWI comes into play. So in the peripheral zone, because of this T2 change being non-specific, it's the diffusion-weighted imaging that we pay attention to in the peripheral zone. Conversely, as I mentioned already, when we're in the transition zone, it's the T2 that we want to look at. So this histology just shows all the small dots here are all vessels. And we can see them regardless of whether it's a stromal component T2 or a more cystic type component, they have vessels throughout. And this video shows you that. So you can look at the peripheral zone around the outside, and it looks like it doesn't enhance at all the normal peripheral zone, whereas the transition zone in the center is very heterogeneously enhancing because there's lots of vessels in there. So that's why the DCE is not going to be so good. And as we've said, they can be very cellularly dense, and we can have foci of restricted diffusion in dense nodules, stromal or densely packed nodules of BPH. So that's why we actually default to the anatomical T2 weighted imaging as the key sequence, the dominant sequence in the transition zone. This is just an example of some prostatitis. So if you look at the peripheral zone there, there's diffuse hyperenhancement within the peripheral zone, matching the transition zone, actually washing out as well by this later stage. You'll see as that video comes around again. Now that isn't positive on DCE because it doesn't fulfill those 3 criteria that we talked about. So as the video goes around again, if you keep an eye on that peripheral zone, you'll see there'll be marked early enhancement. Sorry, let's just go back and play that. So you'll see here where I'm highlighting marked early enhancement within the peripheral zone, matching that transition zone enhancement. Whereas if we go back to this video of the normal peripheral zone, it looks like it doesn't enhance at all. It's a bit of a trick of the eye. It's just not enhancing as much as everything else. And the heterogeneous transition zone is markedly enhancing. So so that is not positive though, because it's not focal and it's not enhancing earlier than the background zone. It's all enhancing the same. And take my word for it, I haven't showed you the other sequences, but it's not matching an abnormality on T2 or DWI. So it's not positive on DCE, even though it shows early enhancement. And then we have this concept of the secondary sequence, which I'll show in a diagram in a second, that they can potentially upscore an indeterminate score. So in the peripheral zone, DCE is the secondary sequence, and in the transition zone, it's DWI. So we use this sort of conversion table, if you like. So in the peripheral zone, the dominant sequence is DWI, as we keep emphasizing. So if the DWI score is 1 or 2, the final PIRAD score is 1 or 2. If the DWI score is 4 or 5, the final PIRAD score is 4 or 5. And it's only if we're sitting on the fence with a score 3, which we're unsure about, we can then default to our secondary sequence, which in the peripheral zone is TCE. So if that secondary sequence is positive, it will upscore the score 3 to a score 4. And if it's negative, it remains as a score 3. In the transition zone, it's similar principles, but now, as we've said, the dominant sequence is T2. So a score 1 on T2 is a score 1 overall. The score 4 or 5 on the T2 is a score 4 or 5 overall. And again, we have scope to upscore with our secondary sequence now being DWI. So again, the 3+1 that we have here, but also just to make things complicated, there's scope for upscoring a score 2 to a score 3. So you can have a 2+1 equals 3 in the transition zone if the secondary sequence is positive. And you can also have a 3+1 equals 4 in the transition zone if the secondary sequence is positive. Whereas in the peripheral zone, it's only a 3+1. Now, this is all a little bit complex. And when you're starting out to report, you have the PIRAS descriptors beside you, and you have this conversion table beside you, and eventually it becomes second nature. For the purposes of the 2B exam, all you really need to know is the principles of you have a multi-parametric MRI, the dominant sequences of T2 and DWI, T2 in the transition zone, DWI in the peripheral zone, and DCE generally has a secondary role and a downplayed role within PIRAS. Okay, so let's go on to another case. So I'm going to switch across this. So we should have candidate 3 to do case 3.
Yes, doctor.
So I will just share again the other screen. And you can request control of the mouse. So this case is a 73-year-old man. Let me just get you. You can start with the T2, and you should be able to scroll with the T2. So 73-year-old man with a PSA of 10.37 and no biopsy history. So you should be able to scroll up and down on the T2.
Okay. I'm scrolling. Actually, doctor, I'm not able to scroll. Yes, there's some lag only. So this is a T2 images of MRI of prostate. I'm at the level of the seminal vesicles. I'm scrolling one by one. Oh, sorry, only there's some lag. Yes. Here I can see the zonal anatomy. I can see the peripheral zone. I can see that there is a focal defined area, hypo-intense, which is present in the medial aspect of the central zone. I think it's at the level of the mid gland.
Mm-hmm.
I can see the prostatic capsule. It is abutting the prostatic capsule about more than 1.7 centimeter. So
okay, and what would you want to do next?
I cannot rule out extra prostatic extension. The next, I like to see the diffusion weighted images and the ADC map to further characterize this lesion.
So I'll just bring these up for you. You mentioned 1.7 centimeters or 17 millimeters. What was the purpose of that?
Actually, I hear it in some lecture, doctor, that if there is a contact between the the lesion. At that, we have to say that we cannot rule out the extraprostatic extension.
Okay. And that's the figure that you have in mind, is it? 17 millimeters.
Yeah.
Okay.
Yeah. Shall I scroll or you will scroll, doctor?
Just let's just get this for you. So probably the thing to do is to scroll on the top right, the DCE sequence there, because that will then it keeps it as that early enhancement, and you'll be able to see the others. So if you just use the DCE sequence to scroll on the top right.
In the top right.
Yeah. So where the arrow is at the moment.
This one?
Yeah. If you just scroll now, it should go.
Yeah.
Yeah. Okay. Yeah, that's fine. Yeah. Keep going. Okay. So you've got your area there. So what is that showing on the other sequences?
I think I have to request again now. Yes, this scroll up now. The four noted lesion, I can see that it shows diffusion. Sorry for the lag.
Okay, I've just gone up. I've gone up to that area. Yeah, let's leave it on that slice. Yeah.
Yes. I can see there is a diffusion restriction in the DWI. I can see in the ADC map there is this area showing marked hypointensity in keeping of diffusion restriction or DCE or no need. This lesion, I think the size is less than 1.5, so it will be PIRADS 4.
Yes. Okay. So we won't, but we can measure it, and yes, it depends on the size. We don't definitely think that there's extracapsular extension. We don't definitely think that there's invasive behavior. So depending on the size, it would be either categorized as PIRADS 4 or 5, because you've described marked change on the B-value imaging, marked high signal, marked change on the ADC, marked low signal, focal low T2 signal intensity. Now, of course, because it's marked change on this, it doesn't actually matter what the other sequences show from that conversion table. Once we've got a score in the dominant sequence of 4 or 5, which in this case peripheral zone DWI is dominant, then already we've got a score 4, 5. But we can look at the other sequences, and again, this would be focal on T2, so it'd be a score 4, 5. And it is positive on DCE. It's demonstrating early enhancement. Earlier, it's focal, it's earlier in the background, normal peripheral zone, and it's matching that abnormality on T2 and DWI. So it's positive on DCE. In the interest of time, what I would just say is that be aware of satisfaction of search. So there is also another tiny lesion here. It's a little bit difficult to pick up. Purposes is not necessarily that, but it's to remind you, number one, satisfaction of search is something to be aware of when you're looking at cases, particularly in the exam, because often there's a secondary finding they will want you to look at. I'm not specifically talking about prostate MRI now, but a good thing to do is, while you're describing your key findings in for instance, a plain film, is to be looking around the rest of the chest X-ray or the abdominal X-ray to make sure that there isn't anything else that you may have missed that might be relevant. So satisfaction of search is something to be aware of, and particularly in the exam settings. There's a small lesion up here which has focal restricted diffusion and early enhancement at DCE. That would certainly only be a PIRADS 4 based on size. They were both tumors on targeted biopsy, and prostate cancer is often multifocal. If you look at surgical series, and yes, there's a selection bias when it comes to surgery patients, but in surgical series, 83% of patients have at least 2 tumors. They have a dominant lesion and at least one secondary smaller lesion. So prostate cancer is often multifocal. But the key thing is the index lesions, we call it the dominant lesion. That's the one to identify and to be sure about. But yes, be aware of satisfaction of search. Okay, that's that case. Thank you. We're going to go straight on to another case if we've got candidate 4 ready. So case 4 we're going to do now. So this is, let me load up for you, and I'm going to load, actually, let's load all the sequences so they're ready for you.
Christian, just 1 second. You know, candidate 4 is not with us because of some technical issue.
Okay.
1, are you ready? We'll go back to candidate 1. Or you wanted to show it to candidate 3, this case?
Well, yeah, we can then do reverse order, can't we? So we can go 3, 2, 1 because candidate 3 is already with us.
That's fine. So we are going to candidate 3. You are going to continue with this case, then 2, and then 1, reverse order.
Okay, sure, doctor.
So this is a slightly unusual case in that there's some more history than just a PSA and an age. So I'm going to say this patient has new LUTS is the term, lower urinary tract symptoms, new lower urinary tract symptoms, previous history of bladder cancer, and is presenting with a raised PSA of 6.54. So if you want to have a quick look through there and tell me what you see. So
okay, doctor, shall I scroll or I stick to this?
Yeah.
Images. Okay. In the T2 weighted images, I can see that there is a well circumscribed capsulated
Candidate 3, we have lost you. We cannot hear you.
Yeah.
In the DWI, I can see this lesion. It show relatively high signal focal lesion, show relatively high signal intensity, and in the diffuse intense signal intensity. So now I need to scroll the DCE.
Mm-hmm. Yeah, so that's top right.
I'm scrolling, but there is only some lag, so I'm waiting. Yeah.
Okay, I'm not sure have we got candidate 3?
But only the abnormal thing that it's protruding to the peripheral zone.
Okay, I think we're losing candidate 3 there. So let me just let me take over the case. Okay, so you were describing this area here, I think. So focal low T2 signal intensity area, possibly a pseudocapsid around it. Some artifact on the DWI, but some marked change, marked high signal on the B-value imaging, marked low signal on the ADC. And if we then look a little bit further, if we think about this satisfaction search, well, actually, there's a very similar area here, anteriorly on the left side at the mid-gland level. Not quite so marked change here. Again, some marked change on the B-value imaging. There's some artifact from rectal gas back here. But the interesting thing here is if we go to the DCE, actually there isn't enhancement within this area, but there is some enhancement around the area. And if we go again to this area more anterior, there doesn't obviously seem to be enhancement within the abnormality there, but perhaps there is some enhancement around it. Now, I mentioned that history of previous bladder cancer, which could be very relevant. The other thing with bladder cancer is you often may have had an MRI previously, a bladder protocol MRI, but we'll have coverage often of the prostate. So in this patient here, we do have a prior MRI that was done only 6 months before, and it's a slightly poorer quality MRI. But what you can see is in those corresponding areas anteriorly, there is no change. So prostate MRI, prostate cancer, even aggressive cancer, doesn't tend to grow that quickly. And in a patient that's had bladder cancer and has had BCG therapy specifically, in this case we could correlate that from the history. We think of the possibility of, could this be granulomatous prostatitis relating to that previous BCG therapy? And the fact that they've had that in the history, and the fact that we've had a previous MR in relatively recent time that was normal, gives us that confidence. So that's an important thing to note, because there was still marked restricted diffusion there. So the history in this case is particularly key. So let me just go back to a couple of different slides here to show you, to emphasize this point. So all that restricts is not cancer. So if you do imaging elsewhere, you may have come across this, a thing that we see in neuroimaging. But in this case here, we've got I don't think it likes me switching between. Whenever I switch between, it kicks me out of Zoom. But let's try and not launch the PowerPoint for this, and because we're going to go on to another case after that. And let me just share the PowerPoint as it is, in non-presenter mode. So the video playing here will show rim enhancement within this lesion here. The key thing in this case here is often the history, but it's not low enough signal on the T2. It's actually more getting towards high signal on the T2, and there's very marked restricted diffusion. And actually what you find with abscesses is often they restrict even more than tumors do. So a colleague of mine, Anwar Padani, has described this as being too good to be true. So if you think that something looks very marked restricted diffusion, it might be a clue that it could be an abscess, but you have to go through the process. So that's where DCE can help. So that rim enhancement, as we see with infected collections elsewhere in the body, is a very good clue. And relatively higher than expected signal on T2, and obviously the history. Now, in a case like this, you would expect if they do a digital rectal examination, it's going to be very tender in this area. So that's another thing to check with the clinicians. If they've done a digital rectal examination, and if it's tender on finger palpation, and you would hope the clinical history helps you with that. Fevers, swinging temperatures, inflammatory markers, white cell count, CRP. Okay, and these are other examples here. So this history, very key, 29-year-old dysuria, CRP 100, temperature of 39.3, really marked restriction, high signal on T2, an abscess, and another diffuse case here with a good history for granulomatous prostatitis, bladder cancer, BCG therapy, earlier MR, completely normal, 6 months earlier, and now what looks like quite marked change. And again, another example of granulomatous prostatitis. Okay, let's try and go to case 5. So I guess we would be going back to candidate 2. If that's okay. Let's try to reshare and hope that the switch of screens doesn't kick us out again. But we'll go to this here. So case 5, this is a 61-year-old man with a PSA of 22.3. I'm just going to get the images set up for you, okay, and then I can let you know when to scroll.
Yeah.
Let's just get we'll put again T2 in the top left, DCE in the top right, and then our diffusion weighted imaging on the bottom row here.
Okay, so
you can now have control. Through that.
Yeah, can I try?
Yeah.
Axial images MRI prostate. So I can see that there is quite curvilinear lesion, mainly in the transitional zone. Sorry, it is mainly in the peripheral zone going into the anterior fibrous zone and the transition zone as well. So it's quite ill-defined medially. It has low signal intensity in T2 and high signal intensity in diffusion with drop of signal in the ADC, so it is restricted. Going to the dynamic contrast images, it has homogeneous contrast enhancement.
And what were the 3 things we look for in DCE to be positive? Do you remember those?
The size of the lesion and the pattern of enhancement, and if there is extra capsular or beyond the prostate, if there is enhancement outside the prostate.
Okay, so we want it to be focal and to enhance earlier in the background tissue and to match an abnormality on T2 or DWI. So that's fulfilling all those criteria. Yeah, so there's focal. If you compare it to this is the left-hand side of the gland. If you compare it there to the right-hand side of the gland, the opposite side has no enhancement. So it's focal and earlier than the other side, and it's matching that abnormality on T2 or DWI. Okay, so what do you think? What would your PIRAD score for this be?
PIRAD 4, giving the size and the enhancement.
So I think this is probably, without measuring it, does look more than 15 millimeters. So that would make it 50. So let's say it's 20. It's probably about 22 millimeters in size. So what would you give a score for at 22 millimeters in size?
PIRAD's 4, the highest one.
So 5. 5 is the highest.
5. So sorry, yeah, 5.
Yeah. And you mentioned about sort of capsular contact. What do you think this is still within the prostate, or do you think it's going outside the prostate?
Yeah. When I correlate the contrast with the ADC and I can see in the ADC there is it is quite confined to the prostate, so I think it is within, not going beyond. Okay.
So it can be a difficult call, and I'll take back control now, and we do look for some different features, and one of the earlier candidates mentioned the degree of capsular contact. Now, what you're also looking for some irregularity. So if we follow where tumor is going here, you've got the lower signal intensity area of the anterior fibromuscular stroma here, and then you've got tumor irregularly going here. So this does look like that goes outside gland, but it can be
infiltrating.
Yeah, and the degree of capsular contact can be useful. Actually, we can try to measure this. Let's just do the length goes from there to there. So it's 26 millimeters. Now, because we don't have a curvilinear tool, but we know straight away this is going to be more than 26 millimeters, right? That's the straight path. So the path around here is obviously going to be longer than that. So we know it's more than that. You can do fancy things where if you don't have a curvilinear tool, you try to measure there, you try to measure there, and you try to measure there, and you add them all together. But we know this is definitely going to be more than 26 millimeters. So there's a broad capsular contact there. So that's another thing that we might look for. So let's move on. We'll stop sharing this. We'll go back to the PowerPoint, and hopefully it doesn't kick us out again. So I'll try to reshare the PowerPoint. So let's move on to a little bit about staging. So generally with the pelvic malignancies, when we talk about the T staging, T1 and T2 is different degrees of organ confined disease remaining within the organ. T3 is when the tumor is starting to go outside the organ, and T4 is when it's invading other organs. So that's pretty much true for all the pelvic malignancies: bladder, prostate, rectal, the gynae malignancies. So that's one thing to think about. So when it comes to T3 disease for prostate, we have T3A where it's going outside the gland, as in this case here. We showed you this one earlier. And these are some of the things that we look for. We look for the capsular contact. So somebody mentioned 17 millimeters. The more commonly used number is 15 millimeters, 15 millimeters, when it's more than 15 millimeters. But it's not black and white. It's not yes or no. It's a continuous spectrum. And the more contact you have, the more likely it is to be going outside the gland at a microscopic level. So above 2 centimeters, there's an 82% chance that it'll be going outside the gland. Most people will use a 15 millimeter cutoff, but it's not hard and fast. We're looking for irregularity of the tissue. So we have some irregularity in this case here at the side. You can see this irregular tissue coming here. We can also look at the neurovascular bundles, which are located here and here. So if you think about a clock face, 5 o'clock on the left side, 7 o'clock on the right side. So any asymmetry that might be present within the neurovascular bundle is something else we look for. And a filling in of this retroprostatic angle, so the angle that it forms with the rectum. And obviously you do have to have a tumor in that location to fulfill that, but a filling in of this angle is something else that we look for, and any sort of bulging of the capsule. So those are various things that we can look for, but it's not an exact science. And I'll show you that on this next slide. So these are various things that we can look for to diagnose T3A disease and extracapsular extension. So you have on one extreme here, you have a lesion that's well away from the capsule, and you can be confident that there's no extracapsular extension. Then you have an example that I've shown here at the other end of the spectrum where you have broad capsular contact, you have some irregularity, you maybe have some things like neurovascular bundle thickening, and you get to the extreme where you have measurable extracapsular disease. But actually, all of these categories here, they might not necessarily be definitively in one category or the other. It could still be organ confined. It might be early extracapsular extension. It might be established extracapsular extension. And the more of them you have, the more likely it is to be extracapsular extension. But it's not an easy call at times. You can play the odds game. So if you have the biopsy result back, and bearing in mind that we're typically doing MRI before biopsy, but you could revisit the staging in the MDT setting at a later stage where you know the biopsy result. If it's a very high risk tumor, then it's more likely to go outside the gland. and the odds tell you that. So if it's a low risk tumor, then it's only 20%. If it's a high risk tumor, it's 77%. And obviously you have to match it in with the imaging as well. But actually the odds are in your favor for a higher risk tumor to maximize calling extracapsular extension if there's softer signs. Whereas if it's a low risk disease, you would maximize saying that it's organ confined disease, but it's not easy. So that's T3A disease. The other thing is T3B disease and involvement of the seminal vesicles. So there are actually 3 different ways you can have involvement of the seminal vesicles. It's not necessary to remember these, and indeed the pathologist never even describe these as prostatectomy. But it's useful to think about how it might happen. So a type 1 disease, a type 1 involvement is when the tumor goes directly into the ejaculatory ducts and up into the seminal vesicles centrally. The type 2 pattern is where you have extracapsular extension and then invasion of the outer wall of the seminal vesicles. And in some cases, you can have large lesions that do both. So this is an example here. We've got direct extension up the ejaculatory ducts, medial involvement of the seminal vesicles, and then actually extension into the vas deferens on both sides. But this large tumor is also causing extracapsular extension and is invading the outer wall of that seminal vesicle as well. So there's a combined type 1 and type 2 involvement. But for both of these types, what you need is you need a tumor at the base of the gland to either go directly into the ejaculatory ducts or to go into the outer wall of the seminal vesicles. And this type 3, which is a metastatic phenomenon, is incredibly rare. So much so that if you have a tumor down at the apex of the prostate rather than the base, it's very, very unlikely to involve the seminal vesicles. You almost don't need to look at the seminal vesicles. Of course you do, and not every patient reads the textbooks, but it's very, very unlikely that you'll have seminal vesicle involvement with a tumor that's not right by the base of the gland. So that's seminal vesicle invasion. And then T4 disease is when you start to invade either the pelvic sidewall or more commonly bladder or rectum, just because of the location of the prostate. So that would be T4 disease. So that's the T staging. The nodal staging, to a degree, it's easy. It's just yes or no. It doesn't matter the size of the nodes or to a degree the location of the nodes or the number of the nodes. It's just yes or no, I think they're involved, or I don't think they're involved. So once you think one or more nodes are involved, you call it N1. If you don't think they're involved, you call it N0. The caveat to that is the non-regional nodes, because actually the non-regional nodes go into the M stage categorization for malignancy, for metastases. So the regional nodes, for the purposes of what we're calling N0, N1, are the obturator nodes, the internal iliacs, and the external iliacs, but not the common iliacs. So once you get to common iliacs, retroperitoneal paraortic, those are non-regional nodes and they come into the M category. Inguinal nodes are also non-regional. It's incredibly rare to get inguinal node involvement at first presentation of prostate cancer. So much so that you would think about something else going on. It's not uncommon to see that in advanced recurrent metastatic prostate cancer, but at first presentation, and when we're doing MR, we're not typically scanning patients with very, very high PSA. It would be very, very rare to have inguinal node involvement. So purposes of inguinal nodes, we look at the short axis, and 8 millimeters is the cutoff. For the non-regional nodes, short axis diameter cutoff is 10 millimeters. There's 3 routes of spread that you can get involvement of the nodes. The most common is this superior lateral spread from prostate to the pelvic sidewall to the obturator nodes to the internal iliacs. You can also have this spread from perineal floor, internal pedental nodes, and then that can, either of these, that can go to the mesorectal nodes, and you can have direct spread to the sacral nodal stations as well. So it's not uncommon to see, it's not the most common, but it certainly can occur where you see sacral nodes, presacral nodes only involved, or you see mesorectal nodes. And that's more common with apical tumors because that's nearer the perineal floor. So with apical tumors in the prostate, it's much more common to see mesorectal node involvement, but the most common is this first one, where you get superior lateral spread to the obturator nodes, the internal iliacs, the external iliacs, and above. So think about that, but it's just to know the mesorectal nodes. Don't immediately think, well, that can't be from prostate. It must be rectum. Let's do a sigmoidoscopy or something else. Absolutely, you can get mesorectal node involvement. You can also get presacral node involvement. Once you're higher than this, your non-regional nodes and inguinal nodes, very, very rare with first presentation of prostate cancer. This is just to highlight that actually the B-value imaging is very useful to identify nodes. So if you look at this T2 weighted imaging, you can work hard and you can see some nodes here, but actually it's much easier on the B-value imaging. Go to the high B-value imaging, it acts as a nodal map. You can see where those nodes are. It doesn't necessarily tell you that they're involved, and in fact these ones aren't, right? Because normal nodes are bright on T1 because nodes inherently have quite a high T2 signal appearance. So you get T2 shine through within nodes. They can also restrict. They can be cellularly reactive nodes can restrict. So it doesn't tell you they're involved. But this B-value imaging acts as a nice nodal map. You can see where the nodes are, and then you can interrogate them morphologically on the B-value, on the T2 weighted imaging. Now, clearly, these are not going to be above size criteria, and they're ovoid in shape. And in this case, they're probably not quite in the drainage space that we would expect. So actually, we can almost dismiss them from the B-value imaging, but you would ideally assess them morphologically on the T2, but you can see exactly where they are from the B-value imaging. So that nodal map of using the high B-value imaging is useful, and that's why I still keep the larger field of view DWI as a high B-value, rather than just having a focused DWI around the prostate, which gives you higher SNR. We actually do 2 in my protocol. But I like to keep that large field of view. And the other thing that you can get with the large field of view is to look at everything else. So it's actually quite a nice screen, that large field of view, high B-value imaging. It's why whole body MR has been quite successful, is the use of the high B-value imaging. And you can see these things, you can see them on the morphological imaging, but it's much easier to see that solitary small nodal met with the high signal on the B-value imaging than it is just on the T2 alone. And this is a large lesion, marked restricted diffusion, but you could miss that, right? It is low on the T2, but it's not that low. You might miss that. And these ones here, you probably wouldn't miss these, but your job is much easier when you have that high B-value imaging to see those areas and then to confirm them. And obviously, there's a large prostate tumor in that case as well. Okay, so we're almost getting towards the end here, but we've got another case to go through before a quick summary, and we might get a bonus case. Let's see. So I think we're back at candidate 1.
Yes, sir, I'm here.
So I'll just try to switch screens again, and hopefully we don't get kicked out. Let's just exit the PowerPoint, and we'll share across. So we're going to go to this case, case 6. So you've got just a CT. So you can scroll through the CT. You started with a CT as well. You've got another CT. Yes. That's just the way it's worked. Okay, so this is a 69-year-old man, left lower quadrant plane, blood in stool, CRP 126, DRE no blood, query diverticulitis.
Okay, I'm presented with a CT scan. I'm just scrolling the images. Okay. Yeah. So I'm presented with a CT scan of the abdomen and pelvis. I will just go through the pelvis in the portovenous phase. And see, there is an ill-defined, irregular, solid lesion with the necrotic center at the deep pelvic region with peripheral enhancement and multiple septation inside. The lesion is centered on the prostate, and it's compressing the rectal bowel loops posteriorly. with some involvement of the anterior rectal wall, which is pushed to the left side with no fat planes in between. There is also extension down to the periurethral location.
I'm just going to take control for a second.
Yes, please.
Sorry, because what I'm going to also put up is I'm going to put an earlier CT that this patient had. So this is from 5 or 6 months prior. So I'm just going to get that into position for you there. So yeah, you can have a look in that area. Just have a very quick look around that area on the earlier one.
Okay. Yeah, it looks normal in this scan. The prostate is normal in the average in size. The rectal wall is well delineated, and the pararectal fat mesorectal fat is clear. The bladder is clear. Both seminal vesicles looks normal. So quite dramatic difference in this scan. There is abnormal. I cannot see any diverticular disease here also, or anything in the rectum, because this might be a possibility as well. Looking back to the colon here, there's some diverticular disease, some tiny diverticuli here. Back again to the new scan. Still, we see the peripheral enhanced lesion centered on the pelvis, distorting the pelvic anatomy, involving the prostate and the anterior rectal wall, compressing the bladder posteriorly, and the prostate itself is not very delineated from this mass. So, and there is also extension down there to the periurethral lesion or region, or in the prostate. So this might represent a large abscess or a necrotic mass. So we have to differentiate between the two. In my routine practice, I will request an MRI to further delineate the prostatic tissue away from or involved in this particular case. I cannot see any lymph nodes or any abnormal pelvic side walls abnormality, no osseous abnormality as well. The pelvic floor looks normal.
Yes.
So MRI, post IV contrast, either rectal protocol or again prostatic protocol, were to further delineate the inflammatory or neoplastic process in this lesion.
Yeah. Okay. Good. I'll take control for a second. The history was quite helpful as well there. So CRP 126, white cell
it's very high. Yeah.
12, lower quadrant pain, and the fact that we've only had 5 or 6 month history between the two studies does somewhat, from a completely normal study previous, does somewhat go against malignancy, certainly a prostate malignancy, but this would be an unusual prostate malignancy, and you can get very aggressive.
Yes.
Rarely, sarcomas in the prostate, neuroendocrine tumors. But in this case, I would be guided by the clinical history. So we said, yeah, we could do an MR now, but actually this fits quite nicely with being abscess. Let's start treatment for abscess, because they've come in unwell enough to be an inpatient now. And we did sort of think about, should we MR now? And sometimes we do, sometimes we don't. We actually waited just 3 weeks and then did an MR at that stage. And you can go up and down that. So that's only 3 weeks later after treatment with antibiotics. So
in this T2 sequence, I can see there is almost complete resolution of the previously described lesion. So it favors the diagnosis of an abscess, a huge prostatic abscess.
Yes. So I think this is the sort of thing that you might get with prostate when it comes to the 2B examination, is an introduction with a CT. So you ended up doing the 2 cases that were like that. So either a large tumor within prostate as your first case, or something that looks quite cystic and multiloculated and could be an abscess. So you might raise that, but you would want to be sure with the clinical history, and an MRI would be the right call. But if there's a very strong history to suggest abscess, a trial of antibiotics prior to an early MR would be a reasonable thing to do, and then to assess for an unusual subtype of prostate tumor, or indeed a rectal tumor that's invading into the prostate, something like a mucinous tumor, you might think,
Yes.
with this low signal intensity as well, a low attenuation. So those might be the thoughts, but absolutely guided by the clinical history.
Dr. Tristan, please, I have a question. Can we do a drainage for that huge abscess? I mean,
so often we do, but this was part of the discussion, was that they seem to be getting better on the antibiotics that have been started empirically, and by the time it was discussed with urology, the question was, well, if they're getting better, why don't we just wait and see, and then let's do the MRI, and then we can see if there's no resolution on the MRI, or if it's not as good as we hope, then we might decide to intervene. But clearly, after 3 weeks and with such a good response, then that was the answer. Was no need. Somebody's commented on the seminal vesicles. Yes, this is just the residual from the resolving abscess. It is probably reasonable to repeat the MR. This is quite a fresh case, actually. It's only from the last couple of weeks. After an interval around 6 months, to make sure that everything has completely resolved and there's not something underlying as to why they might have had that, such as a tumor. But yes, and there's different ways of approaching that. Sometimes you can go transurethral, almost like a TURP procedure, and de-roofing. Other times we've done this, it's our urologists that do it actually, transrectally, to put a needle in and to drain, or transperineally. And the advantage of transperineally is more of an aseptic technique. But you are guided by whereabouts in the prostate the abscess is, and the MR can give you that information. But actually, often they do respond quite well to a trial of conservative management alone, as this particular case did. Okay, let's quickly. We're kind of at the summary slide, so I'll take back control. We'll stop sharing this, and we'll go back to the summary slides. So let's go back to our very first case. So we said the very nice anatomical imaging with the T2, but we couldn't differentiate which of those in the peripheral zone was tumor. Our dominant sequence of the peripheral zone, DWI, shows clear restricted diffusion in one, not the other. That was tumor, and early enhancement of DCE. So if we go through the different sequences, we would start with T1, looking for hemorrhage and an overall screen of the pelvis. We go to T2 to look for morphological change. That's our dominant sequence in the transition zone. We then look at T2 alongside the diffusion-weighted imaging, and that's our dominant sequence in the peripheral zone. And then we move on to DCE, and actually we might already have the answer by that stage, but it's useful for confirming what we see, and it can be helpful in the post-treatment gland, for example, or if we're considering something like an abscess. So that's the basic principles of going through the different things there. Overall summary, the anatomy that we started off with and the terminology is actually very useful to get correct. So the peripheral zone, the transition zone, or transitional zone, and the central zone at the top of the prostate, as we described, and the anterior fibromuscular stroma anteriorly. Higher ads, we use this dominant sequence paradigm, diffusion-weighted imaging in the peripheral zone, DCE is secondary, T2 in the transition zone, DWI is secondary. And knowing that normal and abnormal anatomy is increasingly important for GU radiologists if you go down that route, to help identify and outline targets for biopsy after the original diagnostic MRI, and for radiation therapy planning, and to particularly do boost radiotherapy examples. Okay, so that's all that. I might deal with one or two questions, but I'm keen if one of the candidates wants to do one further case.
Yes, sir, I can do it.
Any of the candidates brave enough?
Yeah. Yes.
So I'm going to switch to showing one further case. Let's open this up. So I'm not going to give you much of a history here. Was it candidate one? You're brave enough to go again, are you?
Yeah, I'm here.
Yes. Okay, and you've got control already. So let's go with this. I'm not going to give you a particular history here. I'm going to give you the T2 imaging up there, and I'm going to give you some diffusion imaging down here.
Okay.
And let's just move that up for you a little bit. That's the sagittal T2, the axial T2 and diffusion. So have a look through that. You should have control, and tell me what you think.
Okay. I'm trying to scroll on the T2, but I will request control again. Just yeah. I'm requesting. Yeah. Okay.
Okay, I've given you that. Yeah.
Yeah, it's moving now. Okay. So I'm presented with the T2 scan, T2 weighted image of the prostate. I can see there is significantly enlarged prostate gland, mainly involving the transition zone. And displaying high signal intensity with a central area of central low signal, linear low signal intensity area. And in the diffusion weighted images and the corresponding EDC map, there is significant restriction. And almost all the lesion, except the central area, it's not very restricted. It shows low signal, so it might represent a fibrous scar or a calcification within the transition zone of the prostate. The transition zone is significantly enlarged in the sagittal T2 as well, and compressing the urinary bladder phase.
Okay, so how would you report this? What score would you give it potentially?
There is no significant low signal on the transition zone on the T2. Obviously, we are dealing with a transition zone lesion, not a peripheral zone.
Okay.
And in the diffusion weighted image, it's restricted. So this is a secondary sign of the transition zone regarding the restriction. So I would like to see the dynamic contrast enhanced image to see if there is an early enhancement of the lesion or it's not enhanced.
I'm going to take back control. We can have a very quick look at there is a post-contrast sequence there. There's not DCE, and the reason there's not DCE is not actually a prostate protocol. And I've been a bit mean here. One thing to check might be the sex of the patient.
Oh.
This is vagina here. They've had hysterectomy previously. You can see vulva down here. This is a female patient.
Okay.
This is a urethral tumor. Turns out to be a clear cell carcinoma of the urethra that looks almost identical in shape to a prostate.
Yeah, very. Yeah.
Now, the exam can be cruel at times. Now, in real life, you're obviously going to know that. Yeah, you're going to know.
No, I didn't see that. Anything.
I know. And you're going to know that if you're on a reporting list, that you're doing it's a female patient and it's a gynae protocol pelvis, and you've been given a history. I deliberately withheld the history. But do at times be careful. The examiners do like to play tricks. So you do have to keep your wits about you for different things.
Yeah.
So that's the only reason I'm showing that it's incredible. It really does look like a prostate, but you can see that it's a female patient, and obviously there's no uterus, which doesn't help matters, but you have the axial imaging coming down here, you have the sagittal imaging. And it's a very cruel way to end, but it's just
it is Dr. Tristan. Yeah.
So I'm sorry, I apologize for that, but
it's okay, but I'll never forget that.
You will never forget that. You will never forget to think about that as well.
Yeah,
that's another thing that sometimes these cases are useful for.
Yeah.
So
Thank you.
let me
Thank
just,
you.
we'll go back to, we're right at the end, but I'm just going to very quickly go back to a quick advertisement. If people are very interested in GU imaging, this is a long way in the future, but I am organizing the ESUR prostate course next June in Cambridge. So we do have red telephone boxes. We don't have Big Ben. We do have King's College. This is a picture of King's College in Cambridge. We're actually at Churchill College in Cambridge. This is in the middle of June next year, 12th to 14th of June. It's quite an expensive course. I don't have control of that, unfortunately. It's run by the ESUR, but it's just if people were particularly interested, that is upcoming. I'll leave that summary slide up there because it also has my Twitter handle if you're interested. And I'll try to have a very quick look in the chat. I realized for that very first case with the artifact, I didn't tell you what the artifact was. Thoughts might be brachytherapy seeds, might be fiducial markers for planning radiotherapy. The location was unusual. It was right at the base level of the gland, at the midline where the urethra lies. That was actually one of the many treatments that they have for BPH and lower urinary tract symptoms, is something called a Urolift device, which goes in the urethra and pulls it apart, and it has metal tips centrally. So it causes artifact in that very specific place at the urethra anteriorly at the base level. So if you've seen something like that before, you know it again. The diagnosis of case 6 was the question, that was abscess. Case 7 there was the nasty female trick case, female patient. It was a urethral cancer. It was a clear cell carcinoma of the urethra. I think there was some question about the lymph nodes. The B-value imaging can act as a nice nodal map, but don't rely on the fact that there might or might not be restricted diffusion. You can't rely on that. You can use the B-value imaging to identify the nodes, and they do have high T2 signals. So part of that is a T2 shine-through effect, but restricted diffusion doesn't reliably tell you that nodes are involved. We still have to rely on the morphology of the nodes, the size, the shape, fatty hilum, irregular, rounded, short axis diameter. So those are the things that you particularly pay attention to. I'm just trying to flick briefly through this. I'm sorry the video didn't play so well. The summary slide at the end sort of shows that approach. T1, T2, diffusion, DCE in that set order. I'm just trying to go through. I don't want to keep people too long, so Sammy, please interrupt me if we need to close, or if you've seen any other relevant questions. There's something about the high B value. The recommended high B value is B1400 and above. You're welcome to go higher than that if your magnet allows you and can get good quality imaging, but B1400 within PIRADS is the lowest high B value that you should go with. I don't see any other burning questions in that. So Sammy, I'll hand back to you. I'm happy to take any other questions you might have highlighted or you might have yourself, and then we can call things to a close.
Yeah, thank you very much for absolutely brilliant session. I think this was highlighted by many of the people. So I'll just ask you some leading questions just to highlight it once again. The video did not play up very well. Many of them could not hear. I could hear, but many of them could. I'm
happy to give you that video as well if you want to host it on your website, if you have that ability.
Yeah, we can do that. We can show it to them on a weekend also.
Mm-hmm.
But just a quick question. This is you were, one of your slides told us that axial is the key axis, right? Mm-hmm. You start from axial and apparently from T1?
T1 axial as well, yes. Yeah.
Your viewing protocol, just a summary of it. You T1 axial?
Yes, I can give you that. I can get that up in the background, but we stick within the PIRADS guidelines for that. And within that, you only need, everything is in the axial plane. And obviously, we're very used to the axial plane as radiologists for most things. But the DCE and the diffusion are only done in the axial plane. And obviously, with the DCE, you only really get one bite of the cherry. You can only give one gadolinium injection. Yes, you could repeat the diffusion in other planes, but obviously, the more you add in, the more time it is. And the axial plane is thought to be particularly key for us. And we don't really prioritize the other planes. So we only need to give one secondary plane as part of the protocol, and that can, for T2, and that can either be sagittal or coronal. The majority of people that I speak to, and we do the same, it's sagittal that we choose as that secondary plane. It's not used that much, and it's only really used for problem solving when we're looking at sort of nodules of BPH, and are they in the right place, are they in the wrong place, this sort of thing. I can show you this from another presentation, which covers our different protocols. We have a multiparametric protocol, which is including the T2, the DWI, the DCE. We have a biparametric protocol without DCE, which there are certain indications we use that for. And we have an abbreviated protocol that we follow up patients on active surveillance in. Now, what you can see with this is true of most things, and don't forget that the appointment time is very different from the scan time. So the appointment time for the multiparametric protocol is 40 minutes, and it adds up to around 25, 26 minutes of scan time, depending on how big the prostate is in the coverage. The biparametric is 30 minutes of patient time in and out, appointment time, but 20 minutes of scan time. And this one's quite tight. It's a 20-minute appointment time, and it's 11.5 minutes of scan time. So there's an extra 14 minutes to get the patient in and out of the room, do all the checks. This is only 8 minutes. So they can't do too many of these in one go. We do an hour slot of 3 back-to-back patients on a Friday and on a Monday. And that's a bit hard on the radiographers to get the turnaround time. But obviously, that's something to be aware of when you're thinking about planning your services. And that's the protocol. Localizers, sagittal, we do first because it helps to see where the prostate is for the radiographers to plan. Then we do axial T2, and then we do axial DWI. And we do those early while the buscopan is still having its effect as the antispasmodic agent. And we don't care so much about the T1, which then comes later. And we have our second DWI sequence as a backup. And then we go on to the DC, because obviously you can't do these sequences if you're giving gadolinium. So that's always going to be the last sequence. And we follow that same thing, but we obviously take some things out on those more abbreviated protocols.
Right, that is absolutely fine. So, apparently upper abdomen, as in kidneys, etc., you are not covering because
so within PIRADS, you don't have to do that. And the idea of doing prostate MR is that we're thinking patients only have localized or locally advanced prostate cancer. So often we will have an upper limit of PSA to refer patients. For us, it's 30 is the upper limit. And obviously, if you've got a PSA in the hundreds, then you're thinking metastatic disease and you're thinking CT, bone scan, maybe whole body MRI. But you're not thinking about doing localized prostate imaging. So the patients that are coming for prostate MRI, that's what you're expecting. You're not expecting disease in the upper abdomen. And yes, there are pros and cons of doing upper abdominal imaging, but you're almost talking about screening, right? For some patients, you'll identify a renal lesion, which is a benefit to them. But for others, you might find an incidental liver lesion that could be an adenoma, could be a hemangioma. It might trigger stress, anxiety, lots of other investigations. So within the guidelines of PIRADS, you don't have to do anything above the pelvis. The only thing they say is that sequence that goes from the bifurcation of the aorta down, i.e. covers the pelvis, to look at the nodal stations, to look at the bony pelvis. You don't have to do upper abdominal imaging.
Right. So thank you very much. I think it was absolutely brilliant, and everybody, I think, must have gained a lot from this. So I am sort of, booked for your 2025 course. So I'll see you there.
You're very welcome. Okay, thanks everyone. Good evening, good night from the UK, or morning, afternoon, wherever you are around the world. Thank you all for joining us.